Hello everyone and welcome to the newborn screening presentation. My name is Caroline. I am the nurse practitioner with the Metabolic Clinic here in Saskatoon, and today I'm going to be talking to you about newborn screening, the do's, the don'ts, and the important tidbits of this particular program, as well as going over some important information for you guys to know in the future. Okay, so to start off with, I thought we could discuss a little bit of the history of newborn screening. This here is Dr. Robert Guthrie. He is considered to be the father of newborn screening. He was motivated to work with people with mental delays due to the birth of his second oldest child, who, as he aged, they realized had intellectual disabilities. In 1957, he met Dr. Robert Wagner, who asked him to come up with an easier way to test for PKU. And coincidentally, in 1961, Dr. Guthrie's niece was diagnosed with PKU, so this added fuel to his fire. He created the dried blood spot testing in 1962 that we use today, and it's still the same test that we use today. So he was obviously very, very smart because he came up with this on the first go. He simplified the test. It used to be a urine test to the current dried blood spots. He tested over 3,000 infants at a school for the mentally retarded at the time and found 23 cases of PKU, which were 4 more than the current urine test could find at the time. In 1962, because of this trial, they were granted permission to do a trial on over 400,000 infants that were born in one of the states in the US, and in 2 years they diagnosed 39 cases of PKU. And because of that, that meant that they were able to be treated immediately, which is very important because that prevents mental disabilities in the future. So all of this information led to a really solid case for newborn screening. And in 1965, newborn screening was introduced to Saskatchewan. Saskatchewan is some of the best newborn screening in the country, and it's always been a leader in newborn screening, so I think that's important to note. In 1978, we added congenital hypothyroidism to the newborn screening panel, and it stayed the same with just the two for a very long time. And then when we developed tandem mass spectrometry, which is a type of testing that we use in the lab, we exploded in the amount of tests that we could run for newborn screening, and now we screen for over 30 different types of metabolic diseases. So what is newborn screening? The screening program has been around since the mid-1960s. Like I said before, we screen for over 30 plus metabolic disorders as well as some endocrine disorders. We screen for hemoglobinopathies, immunodeficiency disorders such as SCID, musculoskeletal disease such as SMA, and endocrine disorders including congenital hypothyroidism as well as others. While each of these diseases that we screen for are quite rare, when you put them together, they actually become a little bit more common in the fact that we will collectively get about 8 to 12 positive newborn screens. These are metabolic newborn screens, not including the other categories, out of every 16,000 babies born in each year in Saskatchewan. So yeah, even though individually we are considered rare disorders, when you put all of these together, we actually remain quite busy with newborn screening throughout the year. Within the metabolic department, we screen for aminoacidemias, fatty acid oxidation disorders, galactosemias, organic acidemias, as well as other genetic disorders. I like this slide just because it gives you a good comparison by province of what is actually screened in per province across Canada. The interesting thing with this is that each province gets to decide what it is fiscally appropriate to test for. A lot of this can depend mostly on cost of the test, but there are other things included, such as in Saskatchewan, we have a founder population for something called Triple H syndrome. So we do additional testing on anybody whose postal code at birth is above a certain latitude. So it's Meadow Lake and up. we actually screen everyone molecularly for this condition because it is so common, whereas the other provinces don't. Some other provinces do have different founder populations and screen based off of that. Anything with a green box here is screened for within that province. The red is not. As you can see, Saskatchewan predominantly has a lot more of the green than any of the other provinces. And the only blue box, which is being considered, we actually now screen for that as well. So, and on top of these, Saskatchewan also screens for another 19 metabolic conditions that are not on this list here. Another interesting point is just to show like PKU is legally responsible for screening across the country, but something that can actually kill a child within a few days of life, such as galactosemia, which is where they can't break down galactose and actually end up getting E. coli, sepsis, and passing away quite quickly. That is something that could be very easily fixed with a soy formula and is very treatable once caught. Quebec doesn't actually screen for that condition, which I find quite interesting. So it really does go to show that when you're being born anywhere in the country, Saskatchewan and Ontario are two of the places that you want to be born because we do have the best screening in the country. So when is a newborn screening done? This is the slide that we're likely going to spend the majority of our time discussing. Legally, the newborn screen can be collected 24 to 72 hours. However, the sooner it's collected, the sooner we get our results. So our fast rule is as close to 24 hours as possible without being less than 24 hours. Now, this is for a couple of different reasons. Number one, being the shipping of these samples. Depending on where you are in the province, you may take up to a day for it to be shipped. Then it has to get to Regina. Then it has to be processed. Then it actually has to be run. And all of this testing takes up a full day in order for us to get our results. So as you can see, depending on the date and time in which it is collected, we could have some significant delays there, especially over a weekend or long weekend, because then the newborn screening department does not run their samples on a Saturday or Sunday or a holiday Monday. So that all has to be taken into account as well. The other portion of this is we have a number of conditions that can actually cause fatalities very quickly after birth. Our 3 previous cases of classical galactosemia, by the time we received the results within the metabolic department, those people were already admitted to either emergency or an ICU by the time we phoned the family. So this causes significant concern, and unless we're involved, people don't know what the concern is. There was also a case a number of years ago where a patient was admitted to an ICU and died fairly quickly, and it was determined that it was classical galactosemia. So we do need to be acting on these very, very quickly. So in relation to the chart, the first column here shows less than 33 weeks or less than 1,500 grams. So these will be the patients that are admitted to NICU. We want that first sample as close to 24 hours as possible, and then a second sample would be done once the patient has been off TPN for 7 days. It is very helpful not to wait until close to discharge to get this done, but indeed get it done once the patient is off TPN for 7 days. The reason for that is that if that then causes an issue that needs to be followed up on, it's a lot easier for our outpatient teams to track a patient who's still in the NICU rather than trying to find this patient, especially if they live remotely. Next, and within that, the reason we're doing a second sample is not because of the TPN. The reason being is because premature infant or low birth weight infant can actually mask a congenital hypothyroidism. So this way, we're allowing a second chance to look at that sample in relation to the TSH. It's got nothing to do with the actual TPN itself. The second column would also be in an ICU patient, and that is the transfused infants. So this is the one that breaks the rule about going less than 24 hours. If you know that a patient is going to be transfused, it is imperative that we get that newborn screen as soon as possible before the patient is transfused, because the transfusion can actually really mess with the molecular blood work as well as the regular screening for the newborn screening. Then you're going to obtain a second sample once the patient is 24 to 72 hours old. Any further additional samples will be directed by the newborn screening lab itself. Any other infant on TPN is the third column, so that would be anyone greater than 33 or plus, or greater than 1,500 grams that just happens to end up on TPN for some reason. These patients only require one sample, and that is the one as close to 24 hours as possible. It is only if a second sample is requested by the newborn screening department that a second sample needs to happen. It does not have to happen just because the patient comes off of TPN. In relation to TPN, the one thing that I will say is that there has been a lot of research lately showing that by stopping the TPN and running D10 instead for 3 to 4 hours prior to the collection of the newborn screen, this does not matter whether you are drawing off of an art line or if you are doing a heel poke, it is the same for both. In that situation, by stopping the TPN, we can drop the false positive rate on a newborn screen by up to 25%. This is huge for patients that are and families that are having to deal with the stress of a newborn screen. So we are doing everything we can to try and drop that false positive rate as much as possible. You can run D10 during the time, which will allow for adequate hydration as well as caloric intake. And then the last one is all other infants. These would be our patients that are born out in newborn nursery or out in the community. Those patients just require that first sample as close to 24 hours as possible. Repeats are only required if the newborn screening department requests one. They will request one if, say, they have an insufficient specimen, if they have an unacceptable specimen, or if they just have inconclusive testing. Overall, if you are not asked for a repeat, do not do a repeat. The other issue that has come up recently in regards to recollection is twins. Twins do not require a second card, and therefore the first sample is good enough. So there are some different possibilities for testing results. There's basically 3 different options. First, you're going to get a negative. That means that the infant has screened negative for all conditions, reports filed, no further testing is required. The newborn screening department may contact either the ordering provider or the unit in which the patient is currently admitted, asking for a repeat sample. So this would happen if the sample is insufficient, unacceptable, or the results are inconclusive. So you'll be asked to collect a repeat sample. And if that comes back screen positive, this means that there's an increased risk for diagnosis that requires further investigations. The screens do not necessarily mean that they have a condition, it just means that they're at higher risk for one. So, if it is one of the metabolic conditions, then the metabolic clinic is notified. And if it is in relation to an elevated TSH or 17-OH progesterone, then pediatric endocrinology is notified. If it is the CF screens, meaning that they've screened positive, they've now been sent for molecular, that has come back positive. At that point, they contact the pediatric CF clinic who contact the family. And then for all the positive SCID, CMV, SMA screens, they contact PEDS ID and genetics, and they have a whole team that becomes involved. So if you are asked to repeat a sample, please follow the instructions of the provincial lab in relation to all collection. Then Metabolics is notified for any positive screen in any of the amino acid ureas, acyl carnitines, biotinidase, and GALT, which screens for galactosemia. One thing to note is that congenital syphilis will likely affect results. We have seen a very large uptick in false positives, specific certain false positives, and it is often related back to a congenital or maternal syphilis. If there is an opportunity for a family to know this, if they could put this on the newborn screening card, it would be exceptionally helpful for us to know that in advance so that we can filter out that sort of information and use it in our analysis, which would be great. So why would you end up with a false positive newborn screen? The biggest ones are always because the patient is in NICU. That is some of our largest reasons. That includes things like TPN, okay, and also liver immaturity or prematurity, the very low birth weight or extreme low birth weight, as well as the congenital syphilis, which I mentioned previously. Now, in reduction in newborn screening false positive results following a new collection protocol, a quality improvement project, which was written in 2021. This is the one that discussed that by running that 4-hour interruption in TPN and running D10 instead, showed that there was a significant drop in false positive rates. So that is something, again, we really want to hammer in, is that TPN, if we could stop it, independent of whether you are going to be drawing that sample off of an art line or off of a heel poke, that would be extremely helpful. So false positive newborn screenings have significant medical and economic implications, including need for further additional investigations and treatments. So there is an added cost for follow-up tests and other healthcare utilization. And previous research also suggests that parents experience significant stress and anxiety when their child is retested after a positive newborn screen, and negative effects may persist even if the result comes back as a false positive. So, earlier investigations have indicated persistent distress among parents of newborns. It stems from inadequate information, understanding, and the timing of confirmative testing. The research has also hinted that false positive results may impact perceptions of a child's health long term, the parental child relationship, and a temporary increase in the utilization of healthcare services. We see this all the time in our families with positive newborn screens, is they often become very concerned about overall health in general and become very highly anxious. So anything that we can do to drop this false positive rate is really important. Making sure the test is done appropriately at the right time, dried long enough, and sent out the way it should are all things that can help with this in the meantime. Other reasons include logistical reasons. So baby's not eaten enough prior to the screen. Sometimes a long fasting time could actually make that, can affect those results. If the specimen's exposed to heat, really important that we don't dry our newborn screening cards either on top of a fridge or in the sun on the windowsill. If the specimen was too small, we do need those dots to be saturated. However, they should not be touching outside of the line, as well as when the test is done too early, so that prior to 24 hours that we talked about previously. So what happens when a positive screen is sent out? What is the process? So all metabolic screens come to the metabolic clinic. They either come directly to myself as the nurse practitioner or to the metabolic specialist, and that we are notified by both email and phone of all positive newborn screens. We then get together and determine what testing is best to be completed on this patient. And this is going to look like, what is the positive newborn screen? How much is it changed? What is the elevation or depression in results? What is the things we need to factor in about the actual baby itself, or how well it's doing, or how it's feeding, how it's looking? All of those things change what we are going to do from a case-to-case basis for follow-up testing. So best testing can include biochemical or genetic testing, or both at the same time. Some metabolic tests can take a minimum of a couple of days for results. Some it could be up to 2 to 3 weeks. Genetic testing could be up to 2 to 3 months. So we need to determine what we need back and how quickly we need it back in order to best move forward. Then the metabolic clinic communicates the plan of whatever we're going to want collected to either the ordering physician on the newborn screen, or to the family physician if the baby's been discharged, or to the care team if the baby is still admitted. Now, when newborn screening blood work is collected, it should be all considered stat. This includes the newborn screen itself, as well as any follow-up testing. It is really important that any follow-up newborn testing be sent as stat, because we need that information as quickly as possible. And the lab should be the one dictating any collection information. So once we tell you what we need, the best people to go to are the lab to figure out how we get that information. What does it need to be in? How much blood do we need? Anything like that can be collected through the lab. The plan for care could involve just testing. It could be dietary changes or management direction. It will not be the same for each condition and can even vary within the same condition. So it's very important that no changes happen until the metabolic team suggest what that direction look like. Okay. The metabolic team will always communicate with the family regarding the newborn screen, any follow-up testing, and any other pertinent information. That looks like us either contacting the family by phone, or if the patient is admitted to an NICU in Saskatoon, we will always try and come and see that family, or we will at least contact the family if the patient is outside of the city. We always try to see them prior to discharge, and while it may not be immediately as soon as the newborn screen has come out, it is a priority of ours to see them if we can. If the baby has already been discharged, at that time we will likely not see the patient in person until we have confirmatory testing as to whether or not a concern is actually occurred. The metabolic clinic will always follow up with the care team, the family physician, and the family with any and all results, and will be responsible for any follow-up for the child after discharge. If this child is in the NICU, please be aware that we will just follow up with this family. You don't have to touch base with us and ask if that's going to happen. Follow-up can either look like a positive diagnosis with resultant long-term follow-up, or they could be discharged from the program with no further follow-up required. How best to talk to parents? What to say, what not to say. So when you are talking to parents, the biggest thing that we need to have communicated to the family is the purpose of the test upon the collection. A lot of times we will phone families and they don't even know what we're talking about when we say the newborn screen. So it really hurts us coming into this conversation with the families immediately, not unsure of what we're talking about. What has happened a lot lately is families will get very defensive in regards to the idea that they think something has been done to their child without their knowledge or say so. So if a parent is electing to not have any newborn screening collected, it is imperative to discuss the reasoning behind this and why the screening is so important. You always have to be willing to discuss this with the families. If a patient really is adamant that they do not want newborn screening, you can always reach out to the metabolic clinic. I would be happy to discuss with a family why this is so important. I truly believe that no one is going to turn down free screening that could save their child's life. However, it does happen. So in those situations, I think education is exceptionally important. Explain what type of results could occur, as well as the process of what could happen if this is in fact a screen positive, which would be very, very helpful. Now, what do you not say to families? Do not go into detail regarding any specific condition on a screen positive. These conditions are exceptionally rare. Even if you Google it, you will likely find out misinformation or information that can just be downright scary to new families. Please allow the metabolic team to go over this information with families, as we know these conditions and we know how to explain them to people. Leave the direction, communication, and information to us. We're happy to take that on. Do not make any dietary changes or any changes to management unless directed by the metabolic team. Some of our conditions used to be treated, now they're not. Some of those treatments have changed. We want to make sure that we're delivering the right information at the right time. And then do not give any timelines on any ordered testing without the direction of the metabolic team. We know how long these tests take, and sometimes if we can tell people, oh, you'll hear from them in a couple of days, and it's going to be a couple of weeks, that can cause anxiety to build. So we want to make sure that we're not doing that to families and that we're giving them the right information. We're always willing to discuss our testing with our families at length if needed. And that brings us to the end. So what is the summary of important points here? We want to never collect a newborn screen before 24 hours unless we're breaking that rule for an infant that is about to be transfused. We are going to collect that newborn screen as close to 24 hours as possible. Our maximum is 72 hours. Please do remember that, we are as close to 24 hours is best, because then we get the results sooner. Obviously, if a child is due to have blood work done 3 hours after they turn 24 hours, you don't have to do that twice. Or, if something comes up and you can't get to them until 48 hours, there is reasonable movement with that timeline. However, what we want to stress is that the closest we can get to that 24 hours is the best for everybody involved. If you are not asked for a repeat, do not do a repeat card. The only category in which an automatic repeat is done is those that are less than 33 weeks or less than 1,500 grams. Please try your best to turn off your TPN for 4 hours prior to newborn screening collection if the child is currently receiving TPN. Any newborn screening blood work, including the original card, should be sent as stat in order to ensure the quickest turnaround and the fastest shipment of those samples. Always counsel your family on the importance of the newborn screen, and if they are choosing to refuse that testing, you may always contact the newborn screening department and ask for advice on how to present this information, or call the metabolic clinic and we would be happy to discuss that testing with the family. Do not give any advice or direction regarding diagnoses, even if you've Dr. Googled it, just because our diagnoses are changing and our treatment is changing so rapidly that often it will not be accurate information that you find online. And do not make any dietary changes for treatment unless directed by the metabolic team, as often we hold off on treatment until such time that a positive diagnosis is determined. And if you have a question, feel free to ask it. Lastly, just in case anybody needs it, these are the important numbers for contact information for the metabolic department within the province of Saskatchewan. At the top, we have the Roy Romano Provincial Laboratory. This is the newborn screening lab. This is their phone number. The St. Paul's Send-Out Department, these are the people that take care of all of the shipments within Saskatoon and surrounding area. All of the samples come to us and then are sent out from that standpoint. If you are dealing with an area outside of Saskatoon, the collecting location will send directly to Regina. The next one we have is the Chemistry 2 lab. If you are collecting within Saskatoon, these are the people to ask in order to get your best collection information. The next one is for urgent inpatient consults. This is the number for SFCC and to get you put through to the metabolic specialist on call. We do have a new metabolic specialist starting with us at the beginning of December. His name is Dr. Spencer Zwarek, and he will be responsible for all inpatient metabolic consults at that time. Below that, we have the metabolic team. These are the numbers for our direct office lines should you need to get in touch with us. There's myself, the RN coordinators, DL and Ashley, as well as the dietitians, our medical office assistant, Jen, as well as our fax number. We value open lines of communication and discussing anything that is needed with our patients. So if that is the case, please reach out to us and we would be more than happy to provide any information required. Thanks.